Hello and welcome to today's press conference out of WHO headquarters in Geneva. It is Thursday, 2nd of July 2026. My name is Christian Lindmeier. I'm welcoming you to today's briefing. Let me introduce the panel to you and then we'll go into the opening remarks. So first and foremost, in the center we have Dr. Tedros Adhanom Ghebreyesus, the Director General. To his left side is Dr. Ghebreyesus, WHE, the Executive Director for Health Emergencies Program. To the side is Anaïs Legon. She's the Technical Officer for High Threat Pathogens at WHO's Emergency Program. Then we have at the far end Dr. Alain Labrique. He's Director Data, Digital Health Analytics and AI. To the other side of Dr. Tedros, we have first Dr. Diana Rojas Alvarez, Medical Officer in Health Emergencies Program, mainly today on hantavirus. And then at the far end there, we have Dr. Vasimoti, the acting lead for the R&D Blueprint and in the Office of the Chief Scientist. We have a couple of other colleagues online in case we get to the topics. One I would like to highlight, and it's Dr. John Otsudiema. He's a Deputy Incident Manager for the Ebola response, and he should be joining us from Ituri. With this, everyone, welcome, and we'll go to Dr. Tedros for the opening remarks.
Thank you, Christian. Good afternoon to those in the room, and good morning, good afternoon, and good evening to those online. Today, the final contact person of a person exposed to hantavirus on the cruise ship MV Hondius completed their quarantine period, tested negative, and returned home. No further cases have been reported since the 25th of May. We're therefore very pleased to say that WHO considers the outbreak of hantavirus over. The total number of cases from the outbreak remains 13, including 3 deaths. More than 650 contacts were identified and followed up by health authorities in 33 countries and territories. Although the outbreak is over, WHO will continue working with governments and partners to advance our understanding of this outbreak and of hantavirus more generally. We're also coordinating a study involving 21 countries to understand how the disease develops, which will support the development of diagnostics, therapeutics, and vaccines for future outbreaks. Once again, I would like to thank all countries that supported the response in line with the international health regulations: Argentina, Cabo Verde, Chile, the Netherlands, South Africa, the United Kingdom, and especially Spain, muchas gracias, which showed incredible solidarity in supporting the safe disembarkation and repatriation of passengers and crew in Tenerife. Meanwhile, in the Democratic Republic of the Congo, the Ebola outbreak continues to expand with an average of 38 new confirmed cases every day for the past 2 weeks. As of today, 1,406 cases have been confirmed and 438 people have died. Under the government's leadership, we have continued to strengthen the response. Testing capacity has now grown to 10 laboratories, set up closer to communities. Contact tracing has improved, with 4 in 5 contacts now being followed up, although there still need to be many more contacts identified per case. And treatment capacity has expanded, with about 650 beds available in 22 health centers, although about 96% of beds are currently occupied, and we're working on adding a further 300 beds. Earlier today, the clinical trial of 2 therapeutics began with the enrollment of the first patient. The partners trial will evaluate the monoclonal antibody MBP134 and the antiviral drug remdesivir alone and in combination. The study is being coordinated by DRC's National Institute for Biomedical Research, supported by a coalition of partners, including WHO, and conducted in close cooperation with the affected communities. Patients who enroll in the trial will receive comprehensive supportive care and close follow-up. We're also working to ensure they have access to the two drugs should they prove safe and efficacious in the trial. Also today, WHO has given emergency use listing to the first molecular diagnostic test for Bundibugyo virus. Despite all this progress, we continue to face significant challenges, including mistrust and violence. Just this week, an Ebola treatment center in Ituri province was attacked, resulting in the deaths of 2 people, and the center was set on fire and patients fled. Such acts not only endanger patients and health workers, but also impede efforts to stop transmission and save lives. The complexity of the outbreak requires close coordination across the United Nations system. And last week, the UN Emergency Relief Coordinator Tom Fletcher and I signed a joint letter endorsing the appointment of Julian Hernias as Senior Ebola Coordinator. Working closely with WHO, national authorities, and partners, Mr. Hernias will reinforce coordination across the response, address operational challenges, and help ensure support reaches people who need it as quickly as possible. In Uganda, no new cases of Ebola have been reported since the 21st of June. However, on Tuesday this week, Uganda notified WHO of a confirmed case of Marburg virus disease in the country's western Ghebreyesus district. The cases were identified through enhanced disease surveillance for Ebola. Health authorities have informed WHO that they're monitoring all identified contacts, but so far none have shown symptoms. WHO is supporting investigations to determine the source of exposure, assess the public health risk, and to support community engagement. The outbreaks of hantavirus, Ebola, and Marburg all show why there is no alternative to international cooperation in the face of international threats. No country alone can fight. Next week, WHO member states will reconvene to continue negotiations on the pathogen access and benefit sharing system of the WHO pandemic agreement. Differences remain, but one thing is clear: countries remain committed to finding common ground and consensus. Now to Venezuela. Last week's earthquake has left more than 2,300 people dead, more than 5,000 injured, and almost 16,000 homeless. As search and rescue efforts switch to recovery, the total number of dead is likely to rise considerably. WHO is coordinating the work of international emergency medical teams who are on the ground providing care for the injured and to support the national health system in providing routine care for those who need it. We have also disbursed $1.5 million from the contingency fund for emergencies, and we have sent more than 6 metric tons of emergency medical supplies, with another 28 metric tons due to be shipped in the coming days. The earthquake compounds an already severe humanitarian crisis, stretching a health system that was already struggling to meet people's needs. Outbreaks and earthquakes capture headlines, But around the world, there is an invisible threat that kills millions of people every year, but gets little attention: air pollution. Prior to 2020, the world made steady progress in reducing air pollution. But new data published by WHO this week show that globally, levels of fine particulate matter, PM2.5, have changed little since 2020. Today, 6.5 billion people are still exposed to air pollution, exceeding WHO interim targets of 35 micrograms per cubic meter. Exposure to unsafe air is 13 times higher in low and middle-income countries than high-income countries. Air pollution is linked to diseases including heart disease, stroke, and lung cancer, and is associated with 6.7 million premature deaths each year. While Asia shows the greatest progress in reducing pollution, Sub-Saharan and Northern Africa have shown little to no change over the last decade. Finally, yesterday, President Emmanuel Macron of France and I published a joint op-ed about the impact of social media and other digital environments on the health of young people. In the past year, several governments, including Australia, Canada, France, Indonesia, Ireland, Spain, and the United Kingdom, have all introduced measures to protect children from online harm. Together, these measures reflect a growing global consensus that digital environments require effective governance, accountability, age-appropriate design, and stronger safeguards to protect child health. Digital environments are not neutral. How they are designed, governed, and monetized shapes many aspects of our lives, including health. For example, repeated exposure to stereotyped, sexualized, violent, or discriminatory content shapes how children understand themselves and the world around them. It can also lead children to make unrealistic comparisons with others, undermining their confidence and self-esteem. Algorithms increasingly filter health information to increase attention and engagement rather than accuracy, allowing misleading claims to spread. And features including infinite scrolling, autoplay, personalized content, and push notifications increase the risk for addictive behavior. The collection and use of personal data, particularly for profiling and target marketing, raise concerns about privacy, manipulation, and well-being. WHO is responding to these concerns by strengthening research, advising countries, and promoting safe, equitable digital health environments. Preventing exposure to illegal or extreme and graphic content is essential. But children's well-being requires more than the absence of harm. It depends on stable relationships, appropriate boundaries, physical activity, and opportunities for real-world social connection. Above all, we must listen to young people. They're not experimental subjects, a captive market, or a commodity. They're our future. Together, we can and must shape digital environments that protect and support their health. Christian, back to you.
Thank you very much, Director General. With this, we come to the round of questions and answers. And to get into the queue for the questions, please raise your hand with the raise your hand icon online, or in the room here, do it without the icon. Let me look around the room first. Yeah, please go ahead.
Laurent Siro, Swiss News Agency. Thanks for the briefing. Now that you have declared the outbreak of antivirus as ended, How concerned are you by that new variant that was found in Argentina lately? And if I may, a short second one, it seems that the biohub in Spitz received as early as the 8th of May one of the samples. Have you had any indication that some countries or scientific have already asked for the sample to be shared with them? Thank you.
Thank you. And Dr. Diana Rojas Alvarez, please.
Thank you very much for your question. So what we are declaring today over is the Andes virus outbreak as associated with the MV Hondius, because it's not longer a public health risk. However, Andes virus and other hantaviruses are still a public health threat for South America and some other endemic areas where it's associated with hantavirus pulmonary syndrome. What we need to continue doing is to keep monitoring these viruses, keep preparing for further spread and controlling and preparing, and of course, involving the community on preparedness and prevention. So what we are declaring today, it's over this specific outbreak, but the work on hantaviruses needs to continue over time, as is an endemic issue in some areas.
Thank you very much. A follow-up, Laurent? Is that?
Yeah, just to know whether you have any indication about the biohub in Spitz that might have been contacted by some countries already?
Yes, we are trying to get the hantavirus into the biohub. It's coming. We still don't have a specific date yet. Thank you.
Thank you very much. Then we have another one here in the room. Agnes from AFP, please.
Yes, thank you. A question concerning the involvement of the enrollment of people for the trials in DRC. How many people do you want to reach in how many days? I don't know if you have already some reaction from the people on the ground, of people interested to be enrolled. Thank you. I don't know to whom ask that question.
I think we start with Dr. Vasimorti. Thank you, the lead for the R&D blueprint.
Thank you. So it's important to see this trial for being integrated into the response and into the overall progress that is being made in scaling up safe, high-quality care. So the progress with the trial will be very much linked with the ongoing maturity of many clinical trial facilities. We're starting in one facility. I think your question was how many people need to be enrolled in the trial. This will depend on the effectiveness of the therapies in the trial. So we have a process in clinical trials where we have an independent data safety monitoring committee that reviews progress of the trial. And so the trial will conclude until we are confident about the results of the trial. From what we see at the moment, this is going to take some time. So we shouldn't expect that this is going to be over in weeks. It will take some months. It could go even into next year. It could be that we need over 1,000 patients enrolled in the trial until we get a definitive answer. That will be earlier if there's a very high efficacy from the trial. In terms of the involvement with the community, we always see the discussions with the community as absolutely central, because all this is about protecting the community. So we have community advisory panels with representatives from all of the relevant trusted stakeholder groups on the ground, so including healthcare workers, community leaders, faith groups, and other leaders on the ground. So all of their input is taken on board, and there are open lines of communication to the trial team from the community so that we can make sure that we always their interests come first. And clearly, in the way that the trial continues, we will absolutely prioritize patient safety and healthcare worker safety in gradually expanding this trial to multiple treatment facilities in Ituri province. Thank you.
Thank you very much, Dr. Morti. Now we come to the first question. No, we don't come to online. There's the third one in the room. It's Chancellor Rostos from Lancet and France 24.
Yes, good afternoon. I've got two questions. First, Dr. Tedros, you mentioned the attacks on health in the DR Congo. I was wondering if that's also affecting patients going to normal health facilities because of fear they might be attacked, and if that's having adverse effects in access to health for other diseases, as we've seen in the past in the Ebola outbreak in West Africa. That was a big issue. And I've got a follow-up question on the artificial intelligence. Thanks.
Let me see where we want to start for technical. Dr. Ghebreyesus, please.
Yeah, thanks. So firstly, the specific attack in Ituri was an unfortunate response to the population, local population being averse to burials of a particular member of that community and responded the way they do. You know, some of these incidents have started to happen from the beginning of the response, and we have continuously improved the response and tried work with the community, inviting them into the care facilities that we have developed, ensuring that they see the quality of care being provided, the access to the community, the empathy with which it's done. And we have seen generally over the last 6 weeks, really a reduction in these incidents more generally, and an increasing confidence in the response itself. Now, obviously, this hasn't been enough to stop these incidents altogether. And every time there's an incident like this, it sets the whole response back. And so what we're doing now is, yes, there's been this specific incident. Our colleagues are in the field, are working with that specific community, making sure that we respond to the specific questions and uncertainties that these colleagues, these members of the community have, but assuring them that there's really no other way around this, that we have to provide safe care for everyone infected, and it doesn't only protect the patients, but everyone else in the community. But, you know, we work in a broader context. The challenges in the Eastern DRC are well known to everyone. There are long-standing conflicts across various groups for various reasons across the entire, the 3 provinces affected. So the outbreak is happening in this context, and unfortunately, the conflict conflation between a very difficult humanitarian context and a very difficult infectious disease context are coming together to cause challenges in responding to this outbreak. As healthcare workers, our responsibility is to continue working across all aspects of the response, supporting clinical care, working with community leaders, assuring them of the quality of care that we're providing, and really going into the community that and explaining to them what we're doing, why we're doing it, and why we need their support and collaboration. And I think, and I hope that there's a long-term lesson to learn out of this, both in responding to this particular outbreak, but actually really working with all the parties. Our Director General has already called for some peace in the province to enable us to our work, but the region really deserves peace in the long term. And if we don't work collectively on all these strands together, we lose an opportunity, not only in controlling this outbreak, but in addressing the longer-term challenges in the Eastern DRC.
Thank you very much, Dr. Ghebreyesus. And you had a follow-up on the...
Yeah, my follow-up was on what Dr. Tedros mentioned in your joint letter with President Macron. I was wondering, sir, if you've got any initial data on the levels of suicide by adolescents in different countries triggered by either digital mobbing or excessive exposure, multiple hours to scenes that have mental repercussions. Thank you.
Thanks, John, again, and we'll go to Dr. Ebola Outbreak, the Director for Data, Digital Health, Analytics, and
Sure.
AI.
Thanks, John, for that question. I think it's clear that today's childhood is being reshaped by digital technology, and we know that social media, gaming, and increasingly artificial intelligence both bring real opportunity for learning, for inclusion of young people, especially those who live on the marginalized or fringes of their communities, and for reaching children in remote and crisis settings. But there is evidence that's emerging that tells us that this might not be a single direction of benefits alone. The same environments are being linked to anxiety, to disruptive sleep, to loneliness, and at their worst, to exploitation and abuse. So the question isn't about whether technology is good or bad. As DG said, it's how we make sure that digital environments are healthy and can support a healthy childhood development rather than undermining it. I think from the evidence perspective, the important message is to keep in mind that it's not moral panic that's driving these bans, but rather emerging evidence that needs to be strengthened. And there is an evidence gap. We know that the scale of adolescent mental health is fairly high. 1 in 7 adolescents live with a mental health condition. 21% of 13 to 17-year-olds report loneliness, which is the highest of any age group. And up to 1 in 5 children aged 12 to 17 in surveyed countries experience online sexual exploitation or abuse in a single year. But most studies we have are cross-sectional and show association, not causality. And so the evidence is mixed and shows both harms and potential benefits. The main evidence gaps are gaps in longitudinal independent research that hasn't kept pace with the technology, especially for generative AI, where long-term effects on relationships, on empathy, on self-regulation are unestablished. I think we also need more evidence from beyond high-income settings, and WHO is pushing for more representative cross-income, cross-region evidence before we lock in global norms. So I think our posture is clear, is precaution paired with active evidence generation, not necessarily a permanent restriction stance.
Thank you very much, Dr. Ghebreyesus. And I think we had a specific part about youth mental health, if I get that right. And let's try if we can get Chiara Servili. She's the technical officer at the WHO Mental Health Department. She should be online, and let's see if we have something on that.
Yes, no, thanks. I think this has been covered well in the previous comment, but let me know if there is anything more that you would like to address.
Could you please repeat, Chiara, because you were very faint in the beginning and we couldn't quite get the part.
Yes, I was saying that this comment has been addressed in the previous response, in relation to what is the current concern in relation to the data we have so far for the relationship between mental health and the use of digital technology. The WHO is promoting increased level of evidence from across different regions to be able to promote an evidence-informed approach to mitigating the risks on youth mental health of the use of digital technology.
Thank you very much, Chiara. We go now online for the next questions. The first goes to Helen Bransworth from STUT. Helen, please go ahead and unmute.
Thank you very much for doing this press conference and for taking my question. I'm looking for more information about the Marburg outbreak in Uganda, please. There's some discrepancy about the numbers. Can you give us an idea of whether WHO believes it is actually one case or that there are more than one confirmed cases? Also, it's been reported that the case is a baby, effectively, a 1.5-year-old. It seems to me very unlikely that a 1.5-year-old would be an index case. I suspect somebody must be looking at the parents and other members of the family. And additionally, is this case living in a refugee camp? And are there any plans underway to try to deploy some of the experimental Marburg vaccines in this situation? Thank you.
Thank you, Helen, and we'll look at Dr. Ghebreyesus.
So thanks, Helen. On the 30th of June, we were informed by the IHR focal point in Uganda on this case of Marburg. detected in Uganda. And remember the context in Uganda. Uganda is next to DRC, already has reported 20 cases of the Bundibujo Ebola outbreak, which in of itself led to a situation of enhanced surveillance across the country, as you would expect. So it was in this context that they identified this case of Marburg. Since then, we have been working, supporting them in Uganda to investigate this case, following up all the contacts, and we will offer more information as it becomes available on the outputs of that investigation currently going on, led by the Ugandan authorities in this particular context. Now, very important to note that the point you made is a very good one of the age of the child, and that's the nature of field epidemiology. Once we find a case, we have to give the context the opportunity to investigate in detail. Uganda has a track history of being actually very good in investigating cases of viral hemorrhagic fevers. I think this is they've had 4 previous outbreaks of Marburg in Uganda, and have always proven, especially in the context of this last Ebola response, their capacities to detect and respond appropriately. So I think for now, we'll leave it to the national authorities to complete the investigation. We're supporting them in the country, and we will report whatever we find with them. They will report, and then we will share with the member states. We've already shared with all our member states through the IHR mechanisms, through the EIS service, shared with all national focal points on what we know about the outbreak at the moment, which enables them then plan appropriate response measures. On your final question on whether there's an opportunity to test some countermeasures, it really depends on the scale of the outbreak ultimately. If it's 1 or 2 cases only, then it'll be very difficult to use that context to test these countermeasures. Back to you.
Thank you, Dr. Ghebreyesus. Next question goes to Rory O'Neill from Political. Rory, please go ahead.
Thanks very much. I was wondering, how do you assess the level of funding coming in to support the Ebola response so far? Because the independent panel had a statement last week where they criticised the level of transparency over the funding pledge so far. Also, the fact that only 90 million of the 910 million pledged has actually been dispersed. So, yeah, do you feel like you have a firm grasp on how much new money has been allocated to the Ebola response, and what is stopping that money from getting to the people who need it? Thank you.
Thank you very much, Rory. Let me look around who should start on the financing of the Ebola response. Dr. Ghebreyesus.
So thanks, Christian. So, like you know, we launched a joint strategic response plan together with the Africa CDC, for which we asked the world for a total of $518 million for the response. The response has been, across the world, has been not, let me find the right words, has been okay for now. We've got quite a number of pledges, and the WHO part of that request is funded to about 35%. There are a few other pledges that have been made, are coming in. We never expect this to come in a week or 2. Sometimes it does take a bit longer. The quicker it comes in, the better for all of us, because we have acute needs to support the response at the moment. But so far, we have enough to do the work that we need to do. And so the availability of resources right now is not stopping any of the work we're doing. We hope that the world continues to act in solidarity with the countries affected and supports the organizations, including ours, supporting DRC in the response. So there's no acute shortfall of resources, but of course, this will not be a sprint. We expect that this response will take a few months, considering the scale of the outbreak and the demands of the response. And we hope that every country that is able to, and other organizations that are able to support the response, continue to do so financially so that we can have a fully funded plan that will enable ourselves and our partners to respond appropriately and mitigate the longer-term impact of this outbreak.
Thank you very much. Next question online goes to Isabel Sacco from FA. Isabel, please go ahead.
Good afternoon. Thank you, Christian. I would like to know if anyone there could give more details on the current state of the health system in Venezuela, especially in Caracas and La Guaira, where it was the epicenter of the earthquake. And if you have any information on how many members of the medical staff have died or are missing. And also, in what extent the aid that is being sent by WHO and that was mentioned by Dr. Tedros is reaching healthcare facilities in Venezuela as quickly as we or you can expect. Thank you.
Thank you very much, Isabel. And we have here with us Ian Clark. He's the Health Emergencies Program and the Incident Manager for Venezuela. So please go ahead.
Good afternoon, and thank you, Isabel, for the question. So maybe before I go into some of the details, I think it's worth just taking a moment to really recognize the incredible work that's being done both by local communities, by national and by international responders in really what's very difficult circumstances. And in many cases, at the community level and the national responder level, these are people who are directly impacted, who have had friends and family impacted by the earthquake. Now, in terms of the overall impact of the health services, I mean, for healthcare workers prior to the earthquake, as Dr. Tedros mentioned, years of underinvestment and the financial crisis has had a major impact in terms of the health services within Venezuela. I don't have an exact figure, but I read a recent report from the Lancet that that in the tens of thousands of healthcare workers have actually left Venezuela over the past years to work in other countries, just due to the lack of investment within the healthcare system. Now, we've seen reports, but again, I don't have a specific number, but yes, healthcare workers have been directly impacted and are missing. One example in La Guaira, the lady who was running the entire maternal pathways is missing and of course is presumed to have perished in the earthquake. So that is having a direct impact in terms of the response. In terms of medical supplies, even prior to the earthquake, there was massive shortages, up to 37% of essential medicines in many of the hospitals. Now, as Dr. Tedros mentioned, we've already provided on the 26th of June, we were able to provide 2.1 ton of essential medical supplies, including trauma kits, protective clothing, body bags, and these have gone directly to the most impacted health facilities. We also have our health cluster partners, some 48 partners, of which 7 of those are working across 37 of the health facilities that are directly impacted in the area. So that aid is getting through as quickly as possible. And yesterday we had another shipment of 4 metric tons, which included interagency emergency health kits, again, more protective clothing, protective equipment, and essential medicines. And again, we have another shipment of around 28 metric tons that it's in our Dubai hub that we hope to mobilize and have deployed to the field as soon as possible. And maybe just to say a word on the emergency medical teams, the government has now made a formal request for the mechanism for the movement of the emergency mechanism. But even prior to that, emergency medical teams had been deployed. So there are now 7 emergency medical teams. Samaritan's Purse, for an example, is fully operational in La Guaira. They have a 48-bed field hospital with 4 IC units and 2 operating units. And additional teams are also on the ground and operational, and 7 additional teams are in process of mobilizing and being deployed. So I hope I covered most of your questions. Thank you.
Thank you very much, Ian. Let me look around the room if anything here. Not, then we go back on the platform. Next is Jonathan Lambert from NPR. And Jonathan, please go ahead and unmute.
Thank you for taking my question. It's about the Ebola clinical trials that are just starting. You mentioned that one facility would be used for the trial right now. Where is that facility? And then a second question, if one or both of these treatments prove efficacious, what steps will WHO be taking to try to ensure that access to these therapeutics is broad across the outbreak? Thank you.
Thank you very much, Jonathan. We go to Dr. Vasimulti.
Thank you for the questions. So the facility is in Ituri province, partly for security reasons. We're not naming the exact facility at this point, just as they get up and running. There are a number of partners that we're working with to bring more and more facilities online. So Alima, MSF, Samaritan's Purse, IMC are partners who are managing these treatment facilities in collaboration with the Ministry of Health and WHO. So we're very grateful for the intense work that is going in with all of these partners. We do hope that we can expand the trial in the right way. So we need to prioritize patient safety and healthcare worker safety as we expand the trial. You raise a really important point, and thank you for raising it, which is that post-trial access is absolutely central to our thinking, to the thinking of clearly communities there in Ituri in whose benefit we are working. So we're working very closely with a number of partners on doing whatever we can to ensure post-trial access. I do think it's worth highlighting that more needs to be done in terms of the ecosystem for access to therapeutics in outbreaks. We have a very well-functioning ecosystem in vaccines, which is fantastic. It's absolutely right that we have a big focus on vaccines, but we also need therapeutics. And where we have CEPI and Gavi for vaccines, we don't have their equivalent in terms of who clearly has the mandate to fund the clinical trials and the post-trial access and then purchase licensed therapeutics. So I think this outbreak is highlighting that. We are working every day with a number of partners, and I would like to mention UNITAID, which has an important role in this link between the immediate steps after the clinical trial concludes. So we don't know when the clinical trials are going to conclude. It could happen sooner rather than, or later. I mean, it could be next year, or it could be perhaps towards the end of this year. So we're in intensive discussions with the US government, which we thank for donating doses of MBP 134, as well as Gilead, which has donated doses. So in both cases, there are discussions about exactly how we can ensure that there will be post-trial access. Thank you.
Thank you very much, Dr. Murti. Next goes to Albert Otti from the DPA, German News Agency. Albert, please go ahead.
Yes, hello. Thank you for taking my question. My question is also on the Ebola trial. Just a clarification question. In your press statement that you sent out shortly before this briefing, it says that the enrollment for the trial has started. So my question is, has the actual trial started? Are patients already receiving the medications, or are you still in the process of drawing up people to participate in the trial? Thank you.
Yeah, and Dr. Murti, please.
Thanks. I think that's a short answer. Yeah, the actual trial has started. So shortly before we started this press conference, by coincidence, the first patient was randomized into the trial. So meaning that they received treatment as part of the trial, embedded into clinical management. So what that means is that they're randomized, just to go into a little bit of technical detail, they're randomized to either receiving remdesivir or not. And then in addition to that, they're also randomized into receiving the monoclonal antibody MBP 134 or not. So we end up with 4 groups, those who receive both, those who receive one, and those who receive the best quality care. So we'll have information on efficacy of either of these therapies on their own, but also in combination. So yes, it has started.
Thanks again, Dr. Murti. So for now, I have 2 questions left online. The first is from The Guardian. Katlai, but I understand the microphone is not working, so I have it in written here, and I'll read it out. Kat asks, what impact is the new DRC rule that people cannot leave the country within 21 days of travel to affected provinces likely to have on the response, for example, for humanitarian workers traveling to support the response? So where should we start? Anaïs Legon, please.
Thank you. So we are following up very closely with the Ministry of Health to review that policy. Just to recall WHO recommendation, contacts of confirmed or probable case should not travel and undergo a 21-day follow-up period to ensure that as early as symptoms may develop, they can receive best level of care and reduce the transmission, obviously. And similarly, people who are suspected cases, meaning that they have symptoms compatible with the disease, they be evaluated and assessed by a health facility as early as possible. And this is the temporary recommendation that the emergency committee states, and we encourage countries to follow them. We are following up with the Ministry of Health to understand better the policy that they would like to implement. Thank you.
Dr. Chikwe.
Yeah, just to add to that, there are very active conversations going on right now with the government of the DRC to define exactly what was sent out was a very broad statement by the leadership of the DRC, understandably, given the context. We're now working with them to really define the details of that, what exactly it will mean and how it can be interpreted for the different categories of colleagues working in the DRC. Our approach always is to have a risk-based approach. So based on the type of work exactly you're doing and your contact with potential patients, then we'll define your risk and then we'll define the level of protection that you need. So there are very specific circumstances that our team in the DRC, together with our partners, the UN, family all together, is working with the government of the DRC to define in detail for everyone going in to support them. Also people living there that need to come out for whatever. Not everyone has the same level of risk. And so we will work with them to come up with protocols and SOPs that they own that will define the travel out of the Ituri province for the next few months.
Thank you both for that. We have one last question, but I understand first we have Jonathan from NPR with a quick follow-up. Let's do this first, Jonathan.
Yes, thank you. I'm wondering if you can say how many doses of either of the two treatments for the Ebola trials have been donated. Thanks.
Dr. Morty.
Yes, we have an initial donation of it's a weight-based dose. So for IV remdesivir, there's really no supply constraints. This is a medicine which we don't expect there to be any supply constraints. So there are many, many thousands of doses. In terms of MBP134, we have what we believe to be no limitation for the trial. So we have, right now, the donation will allow us to proceed with the trial to over 1,200 patients to be enrolled in the trial, which really, according to our calculations, should be enough to conclude the trial. I think that the issue is really more about post-trial access, where it is the case there that we need to have more manufactured. And so we can say that we're in discussions with multiple partners every day about how to accelerate that process of manufacturing additional doses to make sure that we, as far as possible, have absolutely no gap once the trial concludes to providing access of MBP134. Thanks.
Thank you again, Dr. Moti. And I see we have our colleague from Ituri, Dr. John Otsudiema, the Deputy Incident Manager for the response, also wanting to chime in. Please go ahead, John.
Thank you so much for giving me the floor. Just to add on what Dr. Chikwe just mentioned, regarding the 21-day quarantine, the presidential or the government decree will not change, But the good news is that the minister are open, the government are open and ask WHO to work with all partners to revise the SOP. So the implementation will be done based on the risk-based categorization of travelers on frontline and not apply for everyone the same systems. This is one of the things. Meaning what in upcoming 24 hours, WHO will coordinate this revised SOP that will be submitted to the government before starting the implementation of this 21 days quarantine. If we not base this implementation based on this category, that will really happen and affect, our response, of course, not only on our side, but also in their side in terms of someone coming with to support intensive care units in Ebola treatment center for 1 month will be unable actually to, to properly be deployed and support and save, trying to save lives. So in short, as Dr. Shik was saying, but we are working on it. And the government is waiting for WHO to provide all comment to consolidate, so we have a more, detailed implementation plan and SOP to run up to start it to implement this 21-day, which will be risk-based approach. Thank you.
Thank you very much for this add-on, John. And we come to the last question as far as I can see, and that's Jennifer Rigby from Reuters. Jennifer, please go ahead.
Hello, thank you for taking the question. I just wanted to ask for a little bit more clarification about the Marburg case in Uganda. I just want to know, can you tell me when the case was first confirmed? I asked because we had a statement from Africa CDC that suggested that the contacts had been under quarantine for 12 days, which suggests it was 12 days ago. But then WHO was only informed on the 30th of June. And I understood that the WHO should be told within 24 hours if there's a Marburg case. So I'm just looking for a bit more information to help clear that up and deal with that. Thank you.
Yeah, thank you. Good opportunity to clarify. And Dr. Chikwe, please.
So thank you, Jennifer. We were informed of the case on the 30th of June. I can't tell you exactly when the onset of illness of the specific patient was. It's 1 year old, like you know, and those investigations are going on at the moment with the colleagues leading the response in the government of the DRC. So we're confident that as the response evolves, we will be able to offer you more details of this. Like I said, this was not a normal detection. It was a detection in the context of enhanced surveillance that happened in response to the Bundibujo outbreak in the neighboring DRC, which then led to 20 cases of Bundibujo being detected in Uganda. And of course, this case that was initially apparently thought to be Bundibujo, but then confirmed to be Marburg. So as these complex set of circumstances evolve, we would expect the details to be reported to us by the government of the DRC as they lead, the government of Uganda, as they lead the response to the Marburg case. Thanks.
Thank you very much. And just, I think, Dr. Chikwe, you said the government of DRC. That must have been a slip of tongue. So
yeah, sorry, the government of Uganda.
Uganda, exactly. Thank you very much for that. And I see we have Abdi Mahmoud, Dr. Abdi Mahmoud, Director of Health Emergencies, Alert and Response Operations, also having the hand up. Abdi, please go ahead.
No, thanks so much. Dr. Chikwe has covered, but I just wanted to put in context the extensive work done by the Minister of Health Uganda. Since the start of the outbreak with Bundibujo, the government has been conducting mortality surveillance, where all deaths, non-trauma deaths, over 1,000 deaths have been sampled and tested, and all have been negative. Uganda contested around 2,552 samples people have been tested. So that's happening in a heightened surveillance. As expected, we will be able to get sporadic viral hemorrhagic cases. And if you test more, you will find more. And I really would like to recognize again in Uganda's government leadership for expanding that surveillance and for being open on that. But on the other side, the negative impact or the travel restriction that's coming up from other countries is hampering the response. So as we acknowledge the excellent work done and expanding, testing 2,552 people, including 1,000 deaths, it's an incredible amount of work. We need to appreciate and come in support of that. As of that, of course, any suspected viral hemorrhagic cases, there will be contact, and then there will be a further confirmation and the isolation. So the number of contacts you reported and reported by Africa CDC are part of that ongoing investigation. So I just want to take this one to appreciate the excellent work of the extensive, and it's across the whole of Uganda where this mortality surveillance is happening, but also a plea for the other countries. This travel restriction are not helping countries that have been transparently opening data and information.
And thank you very much, Dr. Abdi. And we started with the room, we will close with the room. Last question here in the room, Agnes from AFP.
Yes, thank you. It's a clarification concerning the case of Marburg in Uganda. Because you were answering a question earlier to a journalist who was talking about a baby. So I was wondering if you, WHO, knows the age of the patient, and if you could clarify what is the age of the patient. Thank you.
Do we have an answer? Yeah. Please, Dr. Chikwe.
Yeah, it's, if I'm not mistaken, it's 1 year and 5 months. Yeah.
That was a quick answer. And do you want to add something else, Dr. Chikwe?
Oh, the question was on the age of the baby, and yeah, so I think we can give a precise answer for that one.
Before we come then to closing, no more questions here. Dr. Chikwe, anything else to add?
Yeah, just to say we've had lots of questions on 3 significant outbreaks during this press conference. Firstly, on the hantavirus outbreak, which was very unique in the context of a ship. Patients, not patients, but passengers from many countries across the world traveled and stopped in many countries. A very complex investigation, complex disembarkment process, complex follow-up, difference in management on crew and passengers, and really defines the complexity of the work that was done in response to that outbreak. A second set of questions on the ongoing Ebola outbreak, a viral hemorrhagic fever outbreak of Ebola in the DRC, complex context with this virus that is just emerging for the 3rd time in history, close to 1,500 cases already, ongoing, large response, ongoing at the moment. And with all the complexities that comes with working in the Eastern DRC, with the challenges in that country and the opportunities that also provides now, thankfully, we have the first trial that has started. A third one of the case of Marburg just reported out of Uganda, and the circumstances around the complexities of the mix of surveillance strengthening, leading to the detection of new incidents. Now, of course, the question on everyone's mind would be, are we seeing an increase in these outbreaks? Is this actually uncommon? Do we expect it to be one time in a decade that we have 3 significant incidents happening in 3 months, leading to a significant response by WHO? No, we don't think so. We think that this will continue, and this will definitely be part of the work that we will have to do moving forward. So what does this mean for all of us? How do we respond? Do we respond with increasing travel bans and trade restrictions? Or do we respond by supporting the countries to improve their own preparedness, their own ability to detect and respond? Do we respond in solidarity, or do we respond by isolating these countries? And so those are the questions that are on our minds in the World Health Organization at the moment. And thankfully, in parallel with all the conversations happening, we see many countries building up their national public health agencies, strengthening their own detection and response capabilities. We see a lot of work happening in the R&D space on new countermeasures. We see the IHRs themselves being strengthened and new opportunities to work together in collaboration. The last part of that is the pandemic agreement that we absolutely need to complete with the pathogen access and benefit sharing system that will enable countries to move to ratification as long as that happens. So this is an ecosystem where the risks are there for the world to address, and with the work happening in countries, the work happening in solidarity, the work happening on R&D, the work happening with the new policy and legal environment that the pandemic agreement will provide. Hopefully we can get stronger collectively to respond to these threats. But the threats are not going away. And so the world, we have to decide on how we respond to that together. Back to you, Christian.
Thank you very much, Dr. Chikwe. With this, we come to the end of our briefing today. As usual, we will send the remarks, actually they have already been sent, of Dr. Tedros now, and the files, video and audio files will be shared soon after this briefing. I thank all speakers and all questions, and back to Dr. Tedros for closing.
Thank you to members of the press who are in the room and online, and see you next time.